I would be talking to you about the biosynthetic cornea that we are working at. And the major causes of blindness in our country is cataract. And if you see in the age group more than 50 years, it is corneal opacity, which is the second commonest cause. And if you look at the age group less than 50 years, it is the commonest cause of blindness in our country. So there is a need for biosynthetic corneas, mainly because of the limitation of the human donor corneas. And what we've worked on is the bioengineered porcine construct double cross-linked cornea, which we called as the BPCDX, which is obtained from clinical grade collagen, type 1 collagen, obtained from the porcine skin, and it is doubly cross-linked using cross-linking agents. It essentially looks pretty much like a soft contact lens, except that it is slightly rigid. It comes in thickness of 100 to 500 microns, and the shelf life when in the bottle is 2 years. And it has been made according to ISO and GMP manufacturing and packaging processes. It has undergone all the quality checks, which include the biological safety, the in vivo biocompatibility, the in vivo evaluation, and the ex vivo analysis in the animal model as well. Now, if we compare it with the native porcine cornea, then the fibrils tend to be a little thicker, and also the space between the fibrils is wider. And if we look at the histopathology, then this is the intrastromal implantation of the biosynthetic cornea, which looks acellular, but it integrates well into the tissues where it is implanted. And this is the native porcine cornea, which has cells, and so there's very little difference between the two of them. We use femtosecond laser to create the pocket, but we can use even, you can create the pocket manually also. So with the help of the femtosecond laser, a pocket is created, so much so that the recipient residual bed thickness should be 100 to 120 microns. So you can do it in very thin corneas also. And this pocket is opened first with the help of the, it is opened first, followed by the lamellar dissection, which is done with the help of the lamellar dissector. And this is a biosynthetic cornea which has been triphonated in the same dimensions as the pocket. And this is subsequently implanted intrastromally, and then it is unfolded in the intrastromal pocket, and a bandage contact lens is then subsequently applied. So you don't have to apply any sutures. This is how it looks on the post-op day 1. So this can be seen sandwiched intrastromally, and this is the bandage contact lens over it. This is the second case, keratoconus with pellucid marginal degeneration, and so the thinning is going right up to the periphery. And in this case, again, the pocket is created. So the pocket becomes a little eccentric, and it has to go right up to the periphery, because that is the area which is the thinnest part. After creating this pocket, the lamellar dissection is then done just to reinforce the same pocket after opening it from the superior side. And subsequently, again, the biosynthetic cornea can be implanted in the intrastromal pocket. And this is the intraop OCT microscope, wherein one can see that it is being implanted intrastromally. And this would go right up to the edge, because the thinning part is present right up to the edge. This is followed by a bandage contact lens application. Now, this patient also had cataract, so 3 months down the line, the cataract surgery was also done. And the only thing that you can see is the rim of the biosynthetic cornea, and otherwise the media is very clear. This is the same case which we showed just now. This is the third case again of keratoconus, again where biosynthetic cornea has been implanted, and the K max from 85.9 diopter decreased to 57.1 diopter. And if you compare, this map has also become more regular. This is regular astigmatism, as opposed to this, which has a large keratoconic cone. This is our longest follow-up, now over 7 years. So what eventually happens is that there are some deposits which are seen at the edge of the synthetic implant. Apart from this, it remains fairly clear, and this is very much the type of deposits which are there when you do implant intacs. This is a case of post-LASIK ectasia, where the flap was elevated, which had previously been created, and subsequently the pocket was reinforced all around so that you could implant the biosynthetic cornea there. The synthetic cornea was then triphonated, was placed onto the bed, onto the stromal bed, and the flap was then placed over it, and so again you can see that this is sandwiched and this is markedly thinned out here, which possibly is also the reason why the ectasia occurred. And then sutures are applied because the flap is edematous, so it will not hold on if you just leave it like this. So the sutures are applied, and notice there's so much of thinning. Now again the keratometry here, which was 89.2 diopters, decreased to 50.4 diopters, and pachymetry increased from 241 microns to 581 microns. And again, if you see, the astigmatism has become fairly regular, in fact almost completely gone. In cases where there is haze present, there it may not be possible to make a pocket with the help of femtosecond laser, because it will not penetrate. So a microkeratome is being used here to dissect the anterior part, which is hazy. Some amount of manual dissection was also required here because the microkeratome did not reach up to the hazy part of the cornea. And then subsequently the biosynthetic cornea is taken, is triphonated, and is placed onto the recipient bed, and then it is sutured with the help of the fibrin glue. Subsequently then a bandage contact lens is placed over it, and this would take some time to epithelize because there is no epithelium over it, unlike intrastromal keratoplasty, but does epithelize well and does clear up, although this takes about almost 2 weeks to epithelize, for which you have to place the bandage contact lens. If you see anteriorly on confocal microscopy, you can see the nerves, and posteriorly you can actually also see the endothelial cells which are present surrounding the biosynthetic cornea. So this is a little far-fetched, but I think in times to come, this is something which we are envisioning, that we don't require preservative media or the eye bank or the eye bank personnel or the eye bank paraphernalia. If you can also grow endothelial cells on this stromal construct. And our results, along with the results from another cohort in Tehran, were published in Nature Biotechnology, which has an impact factor of 68.1. And this essentially came out from the study which was done by Dr. Meherdad Rafat in Sweden. We've now done this implantation in close to 70 eyes, and there are no rejections, inflammation, vascularization, or scarring in any subject. And the longest follow-up we have now is 7 years. We also compared the intrastromal keratoplasty using human donor cornea with the biosynthetic cornea, and we did not find any difference in the best corrected visual acuity. However, pachymetry was thicker with the biosynthetic cornea than with the human cornea, because once you implant human cornea intrastromally, there is some amount of attrition that would occur over a period of time. Also, the central corneal thickness was greater in biosynthetic cornea than human donor cornea, and this is just to show the biosynthetic cornea and the human donor cornea, which does thin out over a period of time. Astigmatism, both in terms of the refraction as well as Kmax, was same in both the groups, and there was no difference between the two groups, and so also the higher order aberrations. It is feasible to distribute these corneas. It is not dependent on human donation. It is a simple surgical technique. There are no graft rejections and failures, suture-related problems, and perhaps eye bank facilities minimally involved. And in the event of a complication, although we didn't have any in our cohort, it does not preclude a human graft transplant in the form of deep anterior lamellar keratoplasty. Now, as a further prelude to this, we are trying to grow endothelial cells on this, and this is a project which has been approved by ICMR, and I think when we have that, then we will have a complete corneal construct. So, use of bioengineered corneas for intrastromal keratoplasty is a feasible, safe, and simple technique for corneal ectasias, and tectonically they are better supported when you compare it with the human donor corneas. And I think this is going to be the future, when you just open the bottle and use these synthetic cornea just like you do with intraocular lenses, without having to depend on human corneal donation. And I would like to invite all of you to Asia Pacific Academy of Ophthalmology, which is going to be held with AIOS at Yashobhumi in New Delhi, April 3rd to 6th next year. And Dr. Lalit Verma, who is also the Congress President, is also with us here, and I'm sure he will also invite you for the same. Thank you very much for your kind attention.
Thank you.